Hi everyone, welcome to ECGs. So we're going to be talking about an ECG here, and we're talking about first the sinus rhythm. I think the best thing that we start off with is talking about the sinus rhythm first, like a regular sinus rhythm. So a cardiac conduction system, basically, you start off with blood coming into the superior vena cava from the head and the trunk and the neck, and then blood from the peripheral, which is like your hands and your feet and your abdomen. They go into the inferior vena cava. They go then into the right atrium. Blood goes from here to the right ventricle. Blood goes from the right ventricle to the lungs. And after it gets oxygenated, it comes back into the left atrium. Then it goes into the left ventricle, where it gets pushed out to the rest of the body. So left ventricle is the thickest because it pushes really far. Right ventricle, it is not as thick as the left because it only pushes out to the lungs and back. So as you can tell, left ventricle is very important. Both ventricles are very important because ventricles are responsible for the pushing part. And if something happens here, then your blood won't be able to get to the right places, like your lungs, to get oxygenated, and it won't get it to the body. So of the heart, left and right atrium are important, but the most important are the right and left ventricles. So the cardiac conduction system, so a sinus rhythm, when you think about sinus means basically regular. The word regular is sinus. Not in medical terminology, but specifically for heart terminology, it's sinus. Rhythm is like the lub and the dub, the goom. So you'll see that when the lub dub happens because of these valves, closing and opening. So basically, this conduction system is regulated by the autonomic nervous system of the heart. An autonomic nervous system is dealt with the PNS and the SNS, the peripheral nervous system, which is a rest and digest, and this systemic nervous system, which is the fight or flight. You'll notice the PNS is inhibitory, so it basically helps to decrease the heart rate. It basically is very important in case, let's say, you're working really fast and you're exercising and you need to slow down. Your SNS gets lowered and your PNS gets higher because you want to kind of calm down, right? But let's say you are starting off and you're like sitting down on a desk of a chair, and then something happens and you need to work really fast. Let's say a bank robber comes into the bank and you're working behind the desk. Your rest and digest, it means your heart rate is low, but your fight or flight gets activated, which is like your PNS will become lower, but your SNS will be higher because now you have to increase your heart rate. You have to do fight or flight. Don't worry about these things, Gamo. No big deal. And anything with the SNS, you'll see there's like specific beta blockers and beta. I don't think you need to know those anyways, but whatever. So when the blood comes over here and here, it gets pushed from the heart to the ventricle through this thing called the cardiac conduction system. So from the ANS, which I talked about, helps to increase heart rate or decrease heart rate, and vasoconstrict and vasodilate. So when you have blood here, it has to be pushed from the electrical conduction system through the sinoatrial node, which is the SA node, and the beats for the SA node, basically how fast this goes, determines your heart rate. So the more faster it's being activated through action potentials, the more the heart rate. If it's not being pushed, if it's not being pushed with a lot of action potentials, you'll have a lower heart rate. So if your SA node is not working, you have this thing called a pacemaker that gets implanted. Either when your heart is hella low, your heart rate's really low, or the SA node, the natural pacemaker of the heart, is not working. So you have like an external pacemaker. The SA node, as I mentioned, is a natural pacemaker of the heart. It initiates, so it starts the beats, and it determines the heart rate of our body. And like I mentioned before, ion channels are most dense here. So when sodium, potassium comes in and out of the cell, they are the most potent in this area. So that's why action potentials fire rapidly here. Now it goes from here and it goes down the right atrium into the AV node. And the AV node is called the atrioventricular node. It beats at 40 to 60 specifically. And if the SA node is not working, it's basically the backup. But if the backup is not going to work for way too long, it's just a temporary thing, it needs to have the SA node restarted for it to actually have a regular heartbeat. right? Because your blood still has to come into the right atrium. And for it to actually contract, it needs the SA node. So yeah, like I mentioned, it's a backup when the SA node is not working. It delays electrical impulses to the ventricles. It basically was like, hey, you're going too fast. Stop a little. Let me calm down so I can ventrically push out blood properly into the ventricles. Therefore, the atria will have enough time to fill as well. So when it kind of like slows it down, it makes sure the atria is completely full before it brings the blood from here to here. And basically, depolarization and repolarization will be talked about a lot. Depolarization is when the action potential is having enough to depolarize before contraction. It gets basically stimulated a lot. Repolarization is a time where the stimulation is not that much, so the heart can relax a little bit for filling. When there's a heart hypertrophy, is like the heart is thick and big. But inside of it, if this is thick, let's say this is hella thick, right? Do you see how the small part of my lower left ventricle is getting smaller? The space inside, though, is not enough. It gets smaller. Just because you have a thick ventricle does not mean it's a good thing. Doesn't mean it's strong. Doesn't mean it's like it works hard. If it's hella thick, this actual space inside gets smaller. There's also a dilation. If this part is too big and this part gets stretched out a lot, this skin around this area, left ventricle skin, it will get thinner. And it can happen to both ventricles, by the way. You can have left ventricular hypertrophy or right ventricular hypertrophy, which is a thick one. You can have right ventricular heart dilation, which is like there's a lot of space but a thinner outer edge. And you have left ventricular dilation where there's a lot of space here. And imagine if there's a lot of space here, then the actual muscle on the outside is thin. So both are problems. Now, let's talk about this action potential. So action potentials, as I talked about, let me see a little. Yeah. Action potentials are when sodium starts off going into the cell for the heart. When it reaches from the negative level all the way to threshold at -40, that's when action potentials fire. When the action potential is firing a lot, the calcium, which is specifically only for heart muscle, will go into the action potential as well in the muscle cells of the heart, which is the cardiomyocytes. And then when sodium is going in, calcium is going in, action potential reaches at a higher rate. And the cell is excited when there's more sodium and calcium inside the cell and the potassium is on the outside. The sodium channel closes when it's hella positive, at a point where it's enough positive, right? When basically potassium starts leaving the cell more and more, that is when repolarization happens. This is depolarization. This is repolarization. When it reaches this part, it starts repolarizing as potassium leaves the heart. Now, sodium, potassium, ATPase pump shoves the sodium back out of the cell here and potassium back into the cell with the help of ATP. ATP is your body's natural energy source and it needs to have aerobic metabolism, meaning you need to have oxygen in your body. It's harder when someone is like, let's say, passed out and they're not breathing that much. Your heart automatically is not like pumping that well, right? Because your oxygenation is really low. If you don't have enough oxygen, you can't have enough ATP. So ATP very important for helping with the sodium potassium pump. Now, at this point, when it's out of repolarization, you can't really be excitable. This part right here is when like you don't have a excitable heart muscle. No matter how much sodium will go in this area, it won't be excitable. But as soon as sodium gets back into the cell, it starts doing its own thing again. Sodium is going here, another action potential gets reached over here, and it starts depolarizing, and calcium goes here. It reaches at a point where it's really positive. It goes back down because potassium is leaving the cell. When potassium is leaving the cell, it's called repolarization. It comes to the point where it's repolarized, and it's back to being negative, and it can't be excitable anymore. Now, it does a whole thing over and over again, and that's how we call a heart rate. One of these is a heartbeat. One of these, sorry, not that, sorry, this is not, forget I said that last part. Action potential is just basically what's happening in this area, and that's causing stimulation. Active potential, stimulation. Now, sorry, ECG is a heartbeat. ECGs are the heartbeat. So an ECG is showing the electrical activity of the heart. It doesn't show any of the pumping and filling of the heart. So no contraction and no filling. It doesn't show the systolic. It doesn't show the diastolic. It just shows the electrical activity of the heart. So you'll see how when the ECG, if you have a sympathetic nervous system is activated, it will show a high heart rate. If the PNS is activated, it will lower the heart rate, because the whole job of it is to be rest and digest. The whole job of this one is to fight or flight. So whatever it is, and it's being activated, it will do the actual effects of what it's supposed to do. You'll see ECGs, many leads, but specifically for nurses, leads 2 and 5 are the easiest to read because they line up the most with the person's heart anatomy. I'm sure you're going to learn that on your own, and I don't know how they'll teach you that, but yeah, that's all we do. ECG shows all action potentials are produced by the nodes and the cells of the myocardium. So the nodes, the SA node, AV node, right? Those are the nodes that they're talking about, all the action potentials, and the cells of the myocardium. You're going to see a P, a Q, an R, an S, and then a T. And 1 PQRST equals 1 heartbeat. So this is what I was trying to say when I said a heartbeat. So a bunch of action potentials here are actually, let's say here. So this is a heartbeat. Now let's talk about the ECG. So there are 30 boxes. These boxes right here, so 5 of these is equal to 1 second. And heart rate, and then basically, yeah, that's important for you to know. So if you see there's 5 boxes here, that equals 1 second. And if you count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 30, basically 30 boxes equals a 6-second strip, right? That's very important to know. So if you see 30 boxes and you times that by 10, you'll realize whatever you see in the PQRSTs, you'll have to use the measurement of R to R and see if I see in 30 boxes, I see 1R, 2R, 3R, 4R, and 5R, that means I have 5 heartbeats. And if it's 6-second strip, I'll just have to multiply that by 10 to get, basically, the person has a heart rate of 50, right? Because a 6-second strip times 10 equals 60 seconds, which is 1 minute. Now, if I have 5 of the R to R's showing 1 heartbeat each, then I'll have 50 heartbeats in 1 minute. Okay? You can review that and double check what I said. But basically, I'll show you in a second what I'm trying to say. Now, let's look at the P waves. We'll see the P wave here. There's a Q, there's an R that I was talking about earlier, and then the S, and then the T. A P wave is when the atria of the heart are depolarizing. So depolarizing meaning this part where it goes, that means they have a lot of action potentials happening. Electric stimulation is a lot, so you'll see a peak. The SA node fires here. SA node of the heart, we talked about, that's when the SA node fires. This is a P wave. You'll see a lot of P waves specifically for the SA node. So when you think about SA, think about P waves. Now, sodium is entering the cell to make it more positive, to make the action potential fire, right? And then this has to happen before the heart contracts. So this depolarization does not mean contraction. Depolarization means this happens before the heart can contract. It needs to almost have like you need to press the button of something for it to turn something on, right? So that's almost the same thing. Depolarization is a button that you press before the heart contracts, which is the on part. So when it's depolarized, then the heart can contract. Now, it's only a small wave because it's the atria that are being activated here, right? The atria are being depolarized, and the atria are smaller than the ventricles. So because of that, it depends on the tissue amount. So if you have a lot of atrial tissue, then maybe you'll have a bigger P wave. But in the situation, a regular P wave is that small usually, because the atria itself are smaller than the ventricles. After the P wave, you'll see the P to R. You'll see the P to R, but even then, it's only the R starts here, right? But the R ends in this situation. It's actually meant to be a PQ, but I don't know why they call it a PR segment. So PR segment is basically when the atria contract, right? Mostly it happens here, okay? This does not show a heartbeat. This only shows the electrical activity of the heart, right? We don't see when the heart contracts anywhere. It just shows the ventricles and the atria getting electrical on buttons, okay? So, so PR segment basically is a time when the signal travels from the SA node to the AV node. So P starts off here, SA, to the AV. AV node is this area before the ventricles, right? So atria then contract in this area we talked about. And the AV blocks, if there are any, which I'll go into detail, start in this area, right? So anything before the ventricles are an AV block. That means your heart is not getting past the atria and not able to get perfused by the ventricles, right? Because it's being blocked by something. You'll see that in the ECGs later. But anyways, P wave, atria are being depolarized from the SA node. Now you're going to the QRS. QRS is spiked like this because it's talking about the ventricles. And the ventricles, because the atria here is small, and this is how the amplitude is, the QRS is because the ventricles are bigger tissue, bigger muscle, so they have to have a higher amplitude for electrical stimulation. You'll also see this. Look at that. If the P wave is like this only, that's a P wave, right? Because the atria are only a small amount of tissue to actually electrically stimulate. The right ventricles, though, have so much more tissue. And the left ventricles have so much more tissue because, look, you have to stimulate all of these tissues. Not just here to here. You have to stimulate it from here down when you reach the apex, and you have to stimulate it back up. That's why these QRSs are a lot longer in amplitude, because of the fact that there's more tissue involved. Now, this is a QRS complex. Sometimes it goes by just complex. You'll see a wide complex or a narrow complex or whatever. So sometimes they use the actual words QRS complex or just QRS, but a lot of times you'll see people say just like, oh, a narrow complex or a wide complex. Now, this is when the AV node fires, right? Ventricles are being depolarized. So here, while the electrical stimulation goes from here with the SA node with the P wave, when it goes over here, the QRS. So think about QRS, literally, like that's when the ventricles are being stimulated and being depolarized. Stimulation here means depolarization, okay? So QRS is when ventricles are depolarized. It doesn't mean anything about pumping or filling, just that they're being depolarized. Remember, something has to be depolarized before it contracts. The on button is the depolarization part. The contraction is the actual after the fact that it's been on. Now, you'll see, like I said, QRS, ventricles depolarize. It is a bigger wave and bigger amplitude means up and down. Because there's more mass compared to the atria, right? The atria are just these things. QRS because it's more amplitude because there's more actual tissue. At the same time, the ventricles are depolarizing. The atria silently repolarize. So they're doing this part. They're resting and they're not being stimulated at this time because the ventricles are being stimulated. Now, you go, basically I wrote it here, goes to the back to the original negative charge because potassium is moving out of the cell. Atria is able to relax, right? You can't have two things happening at once. So if the atria is contracting and the ventricle is contracting at the same time, it just won't work out, right? How are you going to have the atria, if the atria are depolarizing and the ventricles are depolarizing at the same time, you can't press two on buttons at the same time and expect things to like pump out properly and fill properly, right? You have to have it in a systematic way. First the atria depolarize, then they'll contract. First the ventricles, and then after that, the ventricles will depolarize, and then they'll actually contract. So you'll see that ventricles are contracting here, and you'll see like the ST part apparently is when the Purkinje fibers are being stimulated from the action potential specifically. So yeah, ST segment is very, very, very important for you, Gamal, because it shows an MI, which is a myocardial infarction, aka it's a heart attack. If it is elevated, so you have to use the isoelectric line. So isoelectric line is basically this line right here. It's an imaginary line you have to create yourself, right? You see how it kind of just falls with the P and the T? Isoelectric. And this will not look like this all the time, by the way. It might be harder to find this because you know ECGs are kind of crazy. Sometimes it could look like this. You don't know what the isoelectric is. Sometimes it's hard to find the ST. But an ST segment shows if there was a heart attack or not. If it's elevated, so if you see the isoelectric like this and you see the STs over here, that means it is a
I didn't get that.
Okay.
Could you try again?
Sorry, my Siri just turned on. But ST, basically, if it's elevated away from the isoelectric, means like, let's say this QRS and it goes here, it shows there is what's it called? A myocardial infarction, right? But if there's also this thing called ST depression, which basically you'll see it goes from QRS, right? But it actually goes below the isoelectric line, and that shows like myocardial ischemia. It's a different type of problem that you have to deal with. But yeah, you'll learn more about that, I'm sure, later. Yeah, so you also have to see this thing. I'm not sure if it really matters for you, but I think it should because you're obviously doing a specialty in this. A prolonged QT interval. So you'll see a Q and then a T. We'll talk about the T in a sec. But a QT is when there's a long repolarization phase, too much recovery, and too much recovery is not great either. You think recovery, you think it's a positive thing, but in this situation, it's only like you have to have a normal amount. If it's, like when someone has a breakup and stuff, and they're literally like sleeping in bed for like, not just like 4 or 5 days, they're sleeping in bed for like 6 to 8 months. You're like, okay, you're recovering, but like, bro, it's been a little too long. Like, that's like unhealthy now, And recovery periods that are too long are not always good. And this is affected by any type of like psych medications, like antidepressants can also do something for this as well. Arrhythmias and then basically if it's too long can lead to cardiac arrest, right? So when you think about recovery period, repolarization is what you think about. But too long repolarization is not great either because your heart's not being able to contract. It's not being stimulated. So that can lead to cardiac arrest. Now let's talk about the T wave. The T wave is basically showing ventricular repolarization. So the resting period of the ventricles. It's not being stimulated by electrical stimuluses, right? Here you'll see the atria depolarize. So it's being stimulated. Depolarization, think about stimulation. QRS is when the ventricles depolarize but the atria are resting, right? And then ventricle repolarization is basically when the ventricles now are trying to do what the atria did before, and they're also resting, right? They need to be able to rest for later on to be having the atria depolarized too, right? Like I said, you can't turn 2 buttons on at the same time. When one button is on, right, atria depolarize, then after that, they can contract. And then if the next button turns on, the other button has to be turned off for the ventricles to contract. It's really difficult to actually understand. I'm sure I'm not explaining it well, but yeah, you can have an actual potential because potassium is leaving the cell, making it more negative. This is a recovery period again before the next contraction. And if you see anything where there's a peaked T wave, anything peaked is higher. So this could be normal, but a peak T wave is like that. It doesn't have to be that way high. It can also be less than that. It can even just be like that, and it's considered a peak T wave. That's showing when someone has too much potassium in their body. Potassium is very, very important for the heart. Calcium is very, very important electrolyte for the heart as well. Both potassium and calcium can cause arrhythmias. But also, if you have too low sodium, problem. Too high sodium is a problem. Sodium is very, very important. So having good electrolyte balance actually affects your heart a lot. You'll realize that later on in life, but that's why people that, let's say someone throwing up hella, right? When you were throwing up a lot for your surgery, we're like, oh my God, is your electrolytes okay, right? Because the more dehydrated you are, the more your electrolytes are going up and down. You don't know what's going on with your electrolytes. You could be having so little sodium, it can affect how fast your heart is beating. If you're having too high sodium, another thing will affect how fast your heart is beating or how slow your heart is beating. Now, if you're having too much potassium, that would be a problem because what if you're beating too fast and you have an arrhythmia? And what if it's beating what if you have too low potassium, then you're having not a strong stimulation. All these things are really important, right? And calcium as well, especially for the heart. Now, Zaha also mentioned this thing called the U wave. It's very important. I think you will actually see it a lot. We as nurses don't really look at it as long as you're specialized, right? Yeah, I think I also mentioned, ST elevation is way worse than ST depression. Anything elevated is really problematic because that shows a heart attack, and ST, when it's lower, it shows ischemia, meaning the heart's not getting enough oxygen. It's called an N-STEMI, right? An N-STEMI is an STEMI basically is an ST segment elevated, right? MI, which is heart attack. An N-STEMI is a ischemia related. It's a non-ST elevation, MI, not ST elevated. This one is ST elevated, and you'll see it in the words STEMI and not elevated STEMI. Okay. Sometimes you can't really see N-STEMIs because in the ECG it's really hard to see, but STEMIs, which is elevated, you can see in the ECGs. That's why people that go into the emerge or whatever, they're like, oh my God, someone has an STEMI, let's get them, blah, blah, blah. They have an active heart attack. They work really fast for these ones. Now, that's pretty much it for ECGs. And I talked about sinus rhythm already, talked about axial potentials. I'm going to talk about a little bit about different types of rhythms. Let's talk about it, actually. So for ECGs, you're going to have to obviously calculate them. When you look for ECGs, you got to calculate their rate, which is heart rate. So it beats from the SA node, right? And I'll tell you how to do that in a sec. You got to calculate rhythm. Is it normal or abnormal? So rhythm is sinus, right? So regular, normal rhythm. Rhythm we talked about is sinus. Come on, remember. Normal, abnormal waves are segments. So you have to check in. You have to really dissect all the segments too. PR, QT, all these segments are very important to really get into. Now, you also have to see the site of pathology. So if it's before the SA node, this is a heart, right? If it's happening before the SA, right? It's happening way before the SA node, before basically the P wave, there's an atria problem, right? If it's between the SA and the AV, that is a PR segment, which is also an atria problem, right? Because the SA is here, the AV is here. This is the SA and AV node, and that's when the PR segment happens, and that is in the atria. So it's an atrial problem. After the AV node, when it goes here, anything after the AV node, you think about ventricles, you think about contraction, you think about QRSs, right? QRS means ventricles are being depolarized, or being stimulated. Anything after the AV node is a ventricle problem. So you'll see a bunch of AV blocks. When they're blocked, when AV is blocked, then it's going to cause a problem here to your ventricles. And I told you already how ventricles are very important for blood to be sent out to your body. So you also have to check if they're stable or unstable. What will it develop it into? Let's say you see a very low sinus rhythm. It can develop into a lot of problems for someone, right? Let's say someone has really, really low heart rate. It's not going to be so beneficial for them to pump blood out effectively, right? Just having a slow heart rate is not a great thing. I told you, having too little is not that bad, but it can be bad. But having too high can be good, but also can be bad. You have to have a good balance between too low and too high, right? Nothing, you might think like, oh, I have a fast heart rate when I'm exercising. That is normal, right? But if I have a fast heart rate when I'm not exercising and I'm just literally just like watching TV or something, that's not normal. So situational also matters, right? You have to see if someone is stable or unstable. If I see an ECG and someone's literally moving around and they're super high anxiety and stuff, I'll look at it and be like, ooh, this is more of a stable patient, because it's not like they're exercising that'll cause a heart rate, right? I might look at it as an unstable patient if it's being super irregulated. Let's say they're having a panic attack. It could literally, like, let's say a high heart rate that you'll see as unstable could develop into a panic attack, could develop into seizures. We don't know. Example would be like having a fast heart rate. You'll see that there's more increased signaling to the SA node, because you know how the SA node, it depicts basically what the frick your heart rate is going to be, right? So if you have a fast heart rate, it's because your SA node is getting so much stimulation. But you can also have a fast heart rate but have normal rhythm. And I told you, anything normal rhythm means sinus. You'll see normal rhythm here, sinus, and tachycardia means fast heart rate. So sinus, tachycardia, it's regular, fast heart rate. Regular, fast heart rate. Regular, fast heart rate. It can be caused by an increased demand. Basically, let's say you've been working out a lot, or you have hella adrenaline. Let's say you came back from a really intense, workout with like yoga people, I don't know. And now it can also be due to fear, anxiety, drugs that people take, like stimulants, like cocaine. You can have electrolyte imbalances like I talked about earlier. You can have hypokalemia, hypomagnesemia. And obviously when you have a high heart rate, it's because your sympathetic nervous system is being extra stimulated, right? If you have a fast heart rate, too much stimulation to the sympathetic, because we talked about how sympathetic is your fight or flight, and the job of the sympathetic is to increase your heart rate. You'll see someone, when you're looking at them, you'll see them sweating, you're having flushed skin, a lot of muscle use, increased heart rate, increased rasps, muscle tension, they'll look more pale. I don't think you need to know all this for more of a nursing thing. Stable, this person is stable because it's a sinus rhythm. It's a regular rhythm. If it was not sinus and something else was going on, I would actually not consider this person stable. If there's this thing called ventricular tachycardia, it's basically when the ventricles are doing too much heart rate, too fast beating, they're not having enough time to fill, then you're not getting enough blood pushed out to the body, is actually a problem. So this person has sinus rhythm, so that means they're actually more stable because they have a normal, regular rhythm. And for anything that's sinus, you just have to treat the underlying stimulus. So let's say if I have a regular fast heart rate, it may be because I just came back from a run. And all I have to do is rest and maybe take like a walk now, You're not running anymore, right? And it's usually short in duration, the stimulus, right? Like I said, if I'm running around causing me to have a sinus tachycardia, It's not like I'm having a sinus tachycardia at rest. I'm literally doing something that's causing this. But if I get rid of that something, it's going to go back to normal. So let's talk about some of these rhythms. Let's look at an ECG here. Let's do a simple ECG first. Let's look at a sinus ECG. Okay, normal sinus rhythm. Okay, now let's look at it real quick. This right here, there's one box. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Now I know this is a 6-second strip. That means whatever I count here of the heart rate, I just gotta times it by 10 to equal how many I'm gonna get per 1 minute. Okay? I can also do that in different ways, but I like to do it. If I know it's a 6-second strip, it's very easy to calculate. But sometimes you look at strips, they're not always 6-second strips, so you actually literally have to calculate a different way. So I'll look at the fact that this one, oopsies, sorry. So look, normal sinus rhythm. Do you see how I know before we looked at it? This is one PQRST, this is one PQRST, this is one PQRST, this is another PQRST. You look how there's a P there, there's a Q, R, S, there's a T, and it goes back to the same thing. P, Q, R, S, T. Do the same thing forever. Now, this is when the atria are being stimulated. This is when the ventricles are being stimulated and the atria are being not stimulated anymore. This is when the ventricles are not being stimulated now. Okay? So, SA node fires here, AV node fires here, and this is all a relaxation, right? So, you'll see how I count this is depending on the R to R, right? This is an R, right? This is an R, this is an R, this is an R, this is an R, this is an R. The peaks of the QRS complex is the R. Now I'm going to count in between my R's to get the heart rate. So I get 1, 2, 3, 4, 5, 6, 7. Since I see 7 of these, 1, 2, 3, 4, 5, 6, 7, I'm getting 1 R, 2 R, 3 R, 4 R, 5 R, 6 R, 7. If I have 7 in a 6-second strip, and I told you a 6-second strip is that second, if I multiply that by 10, I'll get the heart rate in the minute. So that would mean I would get 7 of these equals 70 beats per minute, which is the heart rate. 70 beats per minute. Beats per minute is the same thing as heart rate. The word rate is the same thing as heart rate. So SA node is basically giving me 70 heart rate. This is a normal rhythm. Why? Because 70 is between 60 to 100. 60 to 100 is basically your best friend. Now, have you noticed a 60 to 100 heart rate is the same thing as the SA node? 60 to 100 heart rate is exactly what you're looking for in some person that to have a normal heart rate. And it's a sinus because it's regular, because you'll see that the space between the R to the R is literally measurable at the same. They're literally the same measurements, right? You see how like they're all literally like the same amount of space in between? They're all the same space in between. You're going to look at that to make sure the person has a regular rhythm, which is, you can also call this a normal regular rhythm, but it's also called a normal sinus rhythm. Okay, now this is what you want to see in almost everybody, but it's hard. Obviously, people have different shit going on in their lives. They can't always come back to this. Like, let's say someone had a previous heart attack. Can I come back to this? Not really, not all the time. Very healthy person, seems like, right? In terms of their heart health. Doesn't have to be healthy in other ways, but let's say the heart health is good. Now let's look at sinus bradycardia. So let's look at the, you know how this one has like these things to show that it's a 6-second strip? Sometimes they don't. So you literally have to manually calculate this stuff. And there's more to this. So I got 1, 2, 3, 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 29, 30. Now I can know that this is a 6-second strip. So whatever heart rate I get here, all I have to do is multiply that by 10 to get me the heart rate per minute. Let me count that. Now, you know, the QRS complex, the R is at the top, right? This is my R, this is my R, this is my R, and this is my R. I have 4 R's in a 6-second strip. That means I'll do 4 times 10 equals 40. That is my heart rate. Okay? Now, to make sure it is regular, I'll have to see if it's the same length between each R. R to R, you literally have to measure this sometimes with a ruler. R to R, R to R, they look pretty much regular, right? They look the same. So that's when I'll say they're normal equals regular equals sinus. Okay? This is sinus, and meaning that there is same space in between each R's. And they're also sinus because I see a P, I see a T. I see a P, I see a T, I see a P, I see a T. Right? And it's 40. Now, when you see 40, is it the same thing as 60 to 100, which is what we look for? No, right? It's lower than 60. If it's lower than 60, that means it's bradycardia. Brady means slow. If it's above 100, it's what we saw earlier. It's tachycardic. So tachy means fast. And cardiac obviously is your heart. So tachy, your heart's beating fast. Bradycardic is when your heart's being slow. So this one would be a sinus bradycardia, right? This can be normal in some people if they're like, let's say, really healthy athletes or something, very like active people. Sometimes sinus bradycardia can be good. But let's say if it's like an older person or a pregnant lady, you think sinus bradycardia is good? No, because then she's not getting enough blood being pumped out of her body, and her baby's not getting blood shit either. Right? Perfusion is low. Perfusion is not good. So yeah, we call sinus bradycardia, aka. Now let's look at, we looked at normal sinus rhythm, we looked at sinus bradycardia, and now we'll look at, I don't know if I see this or anything. Okay. Do I have sinus tachycardia here? I guess I don't have sinus tachycardia here, but sinus tachycardia will be literally like the same thing here, but the R to R's will be closer to each other. So you'll see maybe an R here, 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 an R here. And you'll see a bunch of them, right? They all have P's, they all have Q's, they all have R's, they all have S's, they all have T's. But like I have to count that now, right? So let's say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 14. This would be 140, right? Because I know this is a 6-second strip times, 14, right? It will 14 times 10 equals 140. That's going to be my heart rate. This will be a sinus tachycardia if I had those peaks in between, right? I'm counting the R to R's for these things. Now, I want to show you what artifact looks like. It's when there's shakiness, so there's a poor lead placement. This is like, say, maybe you freaking put it wrong, or the person just like came back from the bathroom and then something happened, or like their leads are not working, or they're moving around a lot. You'll see lead 5 sometimes. There's a bunch of leads that you have to know. I don't have to know that unless I'm specializing in cardiology. Lead 2, you'll see like, what the hell is this? Like, why the frick I don't have any kind of like P's, I don't have any Q's, I don't see any R's. I maybe see an R here, but like literally I don't see a proper rhythm anywhere. I don't see a proper P, Q, R, S, T. I don't see that here. I don't see that here. So like, what the frick is going on? Does this person have, like, is this person gonna be a code blue? What the hell? No. This means it's an artifact. It's shaky. It's poor lead placement. Maybe the person is just like moving around a lot in bed. You don't know. Now, there is, let's look at A-flutter and AFib. So AFib is basically atria is fibrillating. So it's basically quivering. When you think about fibrillation, think about it's quivering. So in this situation, the atria is quivering. And it can be either controlled or uncontrolled. If the heart rate is between 60 to 100, that means it's controlled. If it's less than 60 or if it's more than 100, that means it's uncontrolled. So you'll see here in the situation, an AFib. An AFib is an atria problem, and you know atria is responsible for the SA node firing, and you'll see P waves here. So in AFib, you're not going to see a true P wave. You're not going to see a regular true P wave. And you'll notice in the situation, it's not that great, but you don't see a really obvious P wave, right? You'll see a P wave. You maybe see a T wave, right? You see a T wave here. You see a T wave here. T wave is always be after the QRS, right? So if you don't see maybe this is a little bit of a P wave I see, but there's not like a true P wave. Like I don't see a true P wave here. I don't see a true P wave here. Maybe you see one here, but there's not a regular true P wave. You'll also sometimes see premature ventricular contractions. This is like this thing right here. But specifically for AFib, you won't see, and this is an inverted and wide QRS. So this is inverted. Inverted means like the opposite direction, and it's on the wider side. But anyways, for AFib specifically, you're not going to see a P wave. Okay, no true P wave. Even though I see one here, but I don't see one here, do I? I don't see one here as much. I don't see one here, so what the frick? There's no true P wave. Just gonna see one P wave, let's say here or something. I see maybe one. Doesn't mean it's a regular. I don't see that in every single complex. And let's say we have to count this, right? Let's count the boxes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 30. So it's beyond 30 boxes. So I can't use this whole thing to count my times 10 it and equals my heart rate. I'd actually have to count in between, right? So I'll have to count until the 30 mark. So I'll do 1, 2, 3, 4, 5, 6, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 6, 27, 28, 29, 30. So this is my 30, right? So I'll count until the end here. I'll do 1. I won't count this because it's inverted. It doesn't count. 1, 2, 3, 4, 5, 6, 7. Oh wait, sorry. Yeah. I guess that's more like an 80. Forget that. So I'll count 1, 2, 3, 4, 5, 6, 7, 8. This is gonna be times 10 equals 80. That's my heart rate, right? And that's basically how I would count my heart rate for that. And is it controlled? Is 80 between 60 to 100? Yeah, it's controlled. If it was 40, I'd be like, this is uncontrolled AFib. If it was 101, it would be uncontrolled AFib. Okay. Now, similar in the same situation of AFib, where they don't have P waves, atrial flutter also does not have P waves. It does have P waves, but there's no true P wave, right? No true P wave. Let's look at this. Let's count you'll see an A flutter because you'll see a sawtooth kind of look appearance. It looks like a sawtooth. It looks like it's a fluttering thing. It's fluttering. It's butterfly wings, right? You'll see a sawtooth appearance or like a shark tooth, what they say, right? It's like a saw. Like a saw is like this, right? When you have to break down wood. So think about it like this. They will always have a QRS. Always will have a QRS, right? QRS everywhere. But they will have more P waves than technically is needed. You'll have not a true P wave. If you have more than one, that's still not considered a regular P wave, right? Even if you have a lot of them, does not mean it's true. If you have 1 or 2 here and there, like we saw in AFib, that does still not mean it's true. You need to have a consistent amount of P waves in each PQRS to consider it a P wave. So you'll see 3 P waves to 1 QRS. 3 P waves to 1 QRS. 3 P waves to 1 QRS. Like I said, it's a 3 to 1 ratio. 3 to 1 QRS ratio. Now let's count the boxes. This is a regular a 60-second strip. You'll know that only sometimes because of this thing, sometimes it helps, but I like to obviously count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 27, 28, 29, 30. This is my 6-second strip, aka my 60-second strip. If I, whatever I get from here, I multiply that by 10. Let's count our R's. 1, 2, 3, 4, 5, 6, 7. So this would be 7 in a 6-second strip. So 7 times 10 equals 70 beats per minute, aka 70 is my rate, aka 70 is my heart rate. And 70 is how many times my heart is, my ventricles are ejecting those bloods, right? Like we talked about, it's regular. Is this regular? Yeah. Let's look at if it's regular. Regular means it is the same amount of distance from here to there, same amount of distance from here to there, same amount of distance from here to there, and it looks like it is. So it's regular. Yeah, there's no true P wave like I talked about. This is a stable patient because I talked about how this person is regular. Same interventions as, okay, you don't need to know that. SA node is firing like hell, and you'll see that because there's 3 P waves instead of 1 true P wave. So that's A flutter. A flutter and AFib are both atria problems, right? Fibrillation is quivering. Flutter is like this. Now, let's look at ventricular stuff. Let's look at ventricular fibrillation, which is called the VFib. And when I think about fib, think about quivering, right? So look at this. Ventriculars are basically the part of the heart that needs to eject the most blood because of the ventricles, right? The ventricles need to do its part to eject the blood into the lungs or the body. Ventricles are, you're going to remember ventricles equals the QRS, okay? So ventricles, you'll see that there's no QRS and there's no P waves. There's no regularity and it's irregular all the way around. You'll see ventricles are not, you know how the QRS, the amplitude is high because the ventricles are contracting? This one, you'll see like the ventricles are not contracting well because they're not being stimulated well. It's a ventricle problem, and now look, it's quivering. Literally. There's no P's. You don't see any R's. You don't see any QRS's complexes. You don't see a P wave anywhere. You don't see a T wave anywhere. You don't even know what the frick this is. And why is it not no stimulation, really? There's no regularity because look, 1, 2, the peaks are different. The peaks are here, the peaks are there, the peaks are here. There's no like same amount of space in between, right? So like it's not regular. And this is called, and it's a low amplitude because ventricles usually have to have high amplitude. And so if it's quivering, it's not doing its actual stimulation. This is when the ventricles are quivering, and it's literally an emergency sometimes. This is called VFib equals defib. It needs to have a shock. This person needs to be shocked. It's so sad, but it needs to be shocked, right? VFib for defib. Now, let's look at ventricular problem again. So the bottom part, when you think ventricular problem, you have a problem again. So let's look at ventricular tachycardia. And also, in this rate, do you have a heart rate really? No, not really. Right? Ventricular defibrillation, ventricular fibrillation, you literally cannot get a heart rate. This person does not have a heart rate. That's why you need to call code blue. You need to have this person have a shock to get a regular rhythm again. So like I was saying, ventricular tachycardia, in the name itself, you can see it. Ventricles are having a high fast rate. Their heart rate is way too fast in the ventricles. Is that good for blood flow? No. You also may need to call a code for this person if they don't have a pulse. Sometimes ventricular tachycardia can be this thing called pulseless ventricular tachycardia. That's when you will call a code. It is dangerous, and it's also often due to electrolyte imbalances. This also won't have a rate. Ventricular tachycardia can lead to what we call VFib, what we talked about above here, and that will lead to death. That's why you have to figure it out real fast. You'll see this as look at how it looks like. Ventricular tachycardia, do you see this is the QRS. This is called a premature ventricular whatever 3 PVCs. originates in the ventricles is dangerous because there's a wide QRS. Do you see a P wave anywhere? Not really. Do you see a T wave anywhere? Not really. So basically the ventricles are like literally contracting like a lot. Like it's not even like healthy, right? How can you have enough blood flow to the rest of your body if your ventricles are like over contracting and not allowing enough space for the blood to fill inside of your heart? So basically you're just like pushing out nothing, right? If you're pushing out nothing, that can lead to a really, really bad amount of, you're not getting oxygen to your brain because your blood's not getting anywhere in your brain. Your hands, you literally will have a heart attack, right? You will literally just die if you're not getting enough blood oxygen or anything to the brain, right? So you'll see that it looks kind of like this thing called a tombstone, right? It looks like a grave, like the tombstones that people have, unfortunately, when they passed away. You look at that, ventricles or tachycardia, and it's almost leading to death. It's giving you like an overview of what the person can lead into, which is death. So yeah, you look at that, way too high amplitude. Amplitude. That means a lot of, when you see a high amplitude, you think about ventricles because ventricles have more mass, right? They'll have more tissue, so they will have more stimulation. Too much stimulation. And it's tachycardia because look, holy shit, like literally like it's fast. The ventricles are firing fast. Okay? And it only will be considered a VTAC if you see this thing called premature ventricular contraction. Premature ventricular contraction. If you see 3 of these in a row, it's called VTAC. Sometimes you'll have 3 of these, but then you have like randomly like a weird thing going on here. And then you'll have 2 of these and then like a randomly thing. It has to be 3 of them in a row. You can't just have 2 and then random little small one. And then 2 again and then random little small one. That's not considered ventricular tachycardia. It's something else. But you need to have 3 premature ventricular tachycardias in a row for VTAC. And honestly, it's pretty obvious. You just see 3 tombstones in a row. Ventricular tachycardia is like literally 3 tombstones in a row. So yeah, both of these things, you have to realize they need to be called a code sometimes. Okay? But this one specifically is the worst one because you need to have a shock right away. Because this person has literally no rhythm. You can't shock, you can't have any rate. There's no rate at all. You're basically asking for death, right? Now, we went over artifact. We went over normal sinus rhythm. We went over a flutter. We went over a fib. I don't think you need to know about this as much. Now let's look at, and we went over sinus. We'll look at the blocks in a sec, but let's look at asystole. Asystole is like the, right? That's the thing in the heart rate that people see in the doctors all the time. You can't shock this at all because there's literally no P, there's no Q or S, there's no T, there's no rhythm, right? Rhythm is like basically the P, Q, R, S, T. So this person has to have CPR before they can even get a pulse again. They need to come to a point where they have some kind of this for them to have a shock. They cannot be shocked like this because it does nothing for them. In hospitals that we've seen the shows for, they immediately see someone flatlining and they shock them. That's not how real life works, right? If this is someone flatlining, you need to have CPR right away. But they don't do that all the time in hospital shows. Now we know asystole. Will this person have a heart rate? Come on, obviously not, right? Now let's look at blocks. Blocks are very important. So I'll go over the blocks again in general in a sec, but let's look at first degree blocks. First degree all have to deal with the PR and the QRS, okay? So I just want to show you something before I do anything. So ECG graph paper, like I talked about earlier, this is a voltage amplitude. This is a time in seconds, which we've always kind of measured by reading off the amount of blocks. If you see that there's 30 blocks, that means you know it's a 6-second strip. And this kind of shows you that, these little dents. Now, you can also do this by counting the blocks. So 1, 2, 3, 4, 5 is 1 second. And if you have 15 of them, which is like from here to here, that means it's 3 seconds. If it's from 30 boxes, you'll have 6 seconds, right? Like this one. So Now that's pretty much it. When you get this, you multiply by 10 equals the heart rate. Now this is a nitty gritty stuff that you should know. So, sorry buddy. Now, so one of these boxes had little mini boxes. One box is 0.20 seconds, but the mini box is 0.04. So if you have 0.04 and there's 5 of them inside here, then you get 0.20. Okay? 0.20, it's a regular amount in a one box, right? You also see this here. Every box has little 5 mini boxes. So if it's like this way, it's the seconds in time. If it's this way, it's the millivolts. Same thing with actual potentials, okay? Millivolts are like when you're going this way, right? Threshold is at 40, negative 40 millivolts. Times is this way. Time is over a long time. You don't say over a long time like this. You say over a long time this way, right? So think about from left to right is time. Up and down is voltage. And you can also see that with voltage with the V, up and down. The word up and down literally will be part of the voltage name. Okay, now sometimes you have to calculate certain things like the PQRS stuff, right? QRS, you sometimes have to calculate in this thing right here using the boxes. And then PR segments, you have to calculate using sometimes these things. And I'll show you that in a sec. You can also take a picture of this. It's very important for you to understand this because you have to read ECGs. Now, like what I was mentioning earlier, I want to just mention this earlier. A normal QRS, right? Q, which is here, R is here, and the S is here. This time in between of it, it has to be less than 0.12. A normal QRS is 0.12. So you'll see a normal QRS. Let's look at normal sinus rhythm. You have to literally calculate this. And it should be 3 mini boxes at max. If it's more than the 3 mini boxes, which is 0.12, then that's considered a wide QRS, right? If it's more than 3 mini boxes, let's say, it's going to be considered a wide QRS. So that means there's some kind of delay. And if you know that there's a QRS problem, it's a ventricle problem. So there's a ventricle delay somehow, right? Now, and it's like usually it's an AV delay. That's what they call it. Now let's look at PR interval is very important. Every PR interval has to be less than 0.2, right? 0.2 is a max for PRs, okay? Anything more is considered a delay, right? So you'll see that in AV blocks, okay? We'll talk about that in a sec. So 0.2, which is 0.00, same thing. If it's more than that, it's considered delay. Let's look at our normal sinus rhythm. So normal sinus, right? PR segment is this segment from here to here. It has to be no more than 0.20, and you can calculate that by, it has to be this much, P to R. We'll look at the PR segment one more time here. PR segments are literally this thing right here. It can only be, do you see that? 1 block max. If it's 1 block of this, then it's okay. If it's more than that, that means there's a problem. There's a delay, right? And that's when like the SA and AV node, there's a problem. We talked about this. AV blocks happen here. That's one thing. Let's look at the blocks properly now. So first degree AV block, okay? You'll see the QRSs are upright, meaning they're upright, they're not inverted. Narrow, as in like it's fine to be less than 0.12. So QRSs are 0.12. PRs, think about 0.2. You know how QRSs have 0.12? QRS. PRs only have 2 that you have to keep into mind. So P and R. So 2 digits, PR. QRS, 3 digits to worry about. They have to be less than for it to be considered no problem. If it's more than that, if it's more than the 0.2, or if it's more than 0.12, specifically for the QRS, it has to be less than 0.12. If it's less than that means it's good. If it's more than 0.12, that's a problem. So let's look at it. QRSs are narrow and upright. So you'll see the PR, this is a P, this is the R, right? Even though it's technically it's a Q, it's measuring the P to R. So P to R, right? It's more than that one box that we need, so it's delayed. It's a delay in the P and R. The continuous, there's still the same delay. It's still delayed. It's the same measurement of delay though. Do you see that? There's still the same delay, same delay. Do they look pretty much the same? Yeah, you can literally see that they're all the same amount of delays. This is considered PR is delayed because it's more than 0.2 seconds, right? Which is the 5 small little blocks, the 0.04, right? So anyways, if it's more than the big ass block, which is right? Because look, that's a block that we're supposed to have it in, but it's actually more than that. So the PR is delayed, right? And there's a conduction delay between the SA node and the AV node. That means the SA and the AV, there's a conduction delay. That means something's happening. There's a conduction problem. This is called a first degree AV block. It's not like it's life threatening, but it needs to be like attended to. Now let's look at second degree. Second degree, there's type 1 and there's type 2, and I'll go over both of them. Second degree, it is, you'll see that the PR is lengthening. Do you see the PR? This is the P, this is the R, right? Which is actually the Q, but we call it an R and these kind of things for PR segments. So P and the Q, it's this measurement, but then it goes from here to here, and it goes longer, and you see it's longer, and it goes literally like randomly, right? And you see like the PR is lengthening, literally lengthening. So that's considered this type 1 because it lengthens and lengthens and lengthens, and you'll see a predictable drop in the QRS. Here it lengthened, and eventually you see that it's predictably going to drop here because it's so long, right? And the same thing will just continue here and here, and it'll like literally be the same thing. It's a predictable drop. If you want to measure the respiratory, someone's heart rate here, you'll make sure it's 30 here. So it's 1, 2, 3, 4, 5, 6, and 60 beats per minute is normal. But at the same time, it's a second degree AV type 1. It needs to be taken care of because this is not a normal thing to do, right? Just because someone's heart rate is fine, which is 60 here, doesn't mean their rhythm is fine. And that's a problem here. There's a block somewhere. The AV node is not getting anything, so the AV bundle there's a block in the AV bundle. And the AV bundle is the SA to AV, and the AV bundle is here. The bundle of His is here after the AV node. So the SA is firing but not getting through to the AV. Okay, that's type 1. Then there's type 2, which is, I believe, here. Type 2 is basically you're going to have a consistent PR. So your PRs are here, right? You see one PR here, one PR here, and one PR here. They're all consistent, right? But it's an unpredictable drop in the QRS. Like, where the frick is my QRS, right? It's unpredictably dropping. Like, look, there's literally 3 heartbeats. 1, 2, 3, and a drop. But then this one has maybe 1 and 2, and then it drops, right? Even this one, in between, there's 1 here, and it drops, right? Why is it dropping so much? How come it's dropping so quick? So this is more unpredictable, right? And if you want, you can see that their heart rate is 1, 2, 3, 4, 5, 6. 60 is a normal heart rate. But look, even if the normal heart rate is normal, doesn't mean it's regular. This situation, you see there's no regularity. Look, the R to R is farther apart from each other. And also, there's sometimes no QRSs. You need to have a P, you need to have a QRS, and you need to have a T for it to be regular. This is a rhythm problem. Now you'll see that as irregular. It's irregular because the R to R's are irregular. And this is a second degree AV block type 2. Now, the worst of the worst is the third degree AV block. Okay? And that's the worst because the QRSs are regular, let's say. Not regular, but the QRSs are apparent. Like, they're literally, they are regular. QRSs are regular. Do you see that? Same distance between QRSs. Same distance between QRSs. And look, there's the P waves. The P waves are here. P waves, are a little here. But they're literally not working at the same time with the QRSs at all, right? The QRSs are missing here. There's a missing QRS here. There's a missing QRS there. But the QRSs are doing their own thing. They don't give a shit about the P waves, what they're doing. They're doing, literally, it's like when you're boyfriend and girlfriend, but the boyfriend is going off and cheating with other people, and the girlfriend is cheating and doing something with other people, but why are they still together? I don't know, right? There's no synchronization between the P waves and the QRSs. That's a third degree AV block, and it's not good. Okay. Now, I just want to show you one more time the AFib situation. It's irregular because, look, the distance is very irregular. And also, there's no P, there's no Q, there's no R sometimes. It's not true P wave, so that means irregularly irregular. You'll see AFib is considered irregularly irregular. Now, I want to also mention what, I think we went over this one, 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 and we don't have to go over that one. This one, this one, this one, this one. Now, I have to go over supraventricular tachycardia. So when you think about supra, it means on top. And ventricles, tachycardia, fast heart rate. So that means it's very fast heart rate on top of the ventricles. So this is a heart rate of more than 140, usually. So you'll see that it originates as a problem above the ventricles. You'll see the narrow QRSs. It's very tachycardia, right? You'll see the P and the T almost look like they're like conjoined twins. You'll see that as a problem. PR interval is more longer, and QRSs are more shorter. But you're having tachycardia, and sometimes you need to have a vagal response, which is like holding your breath and like really pushing in to actually help with the heart rate. This can be triggered by stress, medications, caffeine. Okay, you need to help with the underlying cause for actually treating this one. Another thing to go over is some things like here. Where is this? PQRS, very important that we talked about. PR interval should be 0.12 to 0.20. QRSs, don't even worry about this. Just look at the PR thing that I talked about. PR should be less than 0.12. Sorry, less than, PR segments should be less than 0.2, right? This. QRSs should be less than 0.12. This one, PR should be less than 0.2. P and R, 0.2. QRS, 0.12. Right? Anything more than that, it's a delay. Okay, now let's go over really quickly some of these things that we talked about. So normal sinus rhythm we talked about already. Very regular, very normal, very demure, 60 to 100. SA node works, fine. Supraventricular tachycardia, it's above the ventricles, above the ventricle problem. You either treat with a vagal maneuver. There's a flutter, remember the 3 Ps to the 1 QRS, like a flutter, like a sawtooth. That means your heart's not contracting well. Even the QRS is irregular. AFib is like basically irregularly irregular. Basically, it needs to be controlled faster. Is quivering of the heart can cause, actually, if your blood is pooling in one place and quivering in your atria, your blood is not ejecting anywhere, and the longer the blood stays together, it could cause clots, can cause strokes, can cause actually a bunch of things. So that's why fibrillation not great. Sinus Brady, so you have to look, it's regular, but it's slow. Now sinus tachy, it's regular, but it's fast. Ventricular tachycardia is ventricles are going way too fast, right? It's not good if it's too fast, right? It can lead to VFib, which is not what we want. And there's such things as stable and unstable. In ventricular tachycardia, you'll see the tombstones. Tombstones are almost like a little warning before death. VFib is when there's literally like the worst of the worst. Right? VFib needs defib. It needs to have shocks. Then there's asystole, you can't shock it, you need to CPR. Now, first degree AV, second degree AV, and third degree AV. Let's go over here. First degree, we talked about the PR are long, right? You still have a QRS. You just have long PRs. It's just delayed. It's more than the 0.2 seconds. It doesn't mean that it's crazy. You're still going to have a regular PQRST. It's just that PRs are long. Second degree, there's a random drop of the QRS somehow, or there's some kind of drop. It has to be either random or unrandom, or it's predictable or unpredictable, basically. Type 1 of the second degree, you'll see type 1, just think about when the PRs are progressively lengthening, okay? And then basically you're going to see a predictable drop in the QRS. You can see here how I wrote it, PR is progressively lengthening, and then eventually, then there's no QRS, and you're back to a normal, and you repeat the same thing all over again. This is a block. Type 2 is like there's a consistent PR. It's normal or it's delayed, we don't know. But there's always an unpredictable drop of the QRS. Okay? Third degree is when the PUAs are doing their own thing, QAs are doing their own thing. They're both regular, but they're just not working with each other, right? It's dangerous because ventricular rate can be too low, and usually ventricles control all of the output of the heart. And both of these things can lead to asystole, which is like the flatline thing that we talked about. Now I want you to take a picture of this one and really just have it in your mind. First, always calculate the rate of things. When you look at an ECG, look at the rate, number of seconds basically, the 6-second count that we talked about, times it by 10. You get the heart rate. You can also do it in this way, where if you look at the R to R's, within 6 seconds, you can multiply by 10 like we talked about, or you look at the R to R's, so in between, you count the boxes in between, right? And then divide by 300, right? Let's look for a normal sinus rhythm, let's say. We know this one was 70, but we can also check it this way by looking at, this one is 1R, 2R, 3R, 4R, 5R, 300 divided by, or actually this is 1R. Okay, how about this one? 1R, 2R, 3R, 4R. 300 divided by 4 divided by 300. 4 times 6. 7 times 4 is 28. So 7 times 4 is 28. And there's 2 left over, 75. So it's around the same, right? Right? We got it almost the same. You can also do it that way, both ways. And like example would be you see 6 squares in between. You have to divide 300 by 6 and you get 50, which is bradycardia. So that's one way of doing it. You basically map out the R to R. You basically find the R and just measure the R to R's peaks and compare it to each length. And if it's consistent, that means it's a regular rhythm. That means it's sinus, okay? Another way of doing this, you have to also systematically approach the ECG. Are there always PUAs before the QRSs, right? If you see that there's no PUAs, that means it could be AFib or aflutter. If there is a different situation, then you can look at that. Are there always a QRS? Make sure you know that, because it could be a block. Okay, then measure the PR. So like we talked about, PR has to be less than 0.2. QRSs are supposed to be measured less than 0.12. If it's more, it's a delay, and it causes a conduction delay. Look at the ST segment. Look at the isoelectric line. Is the ST above? ST elevation means it's an MI, which is a heart attack. ST depression, it's basically the heart's not getting enough oxygen. It's called ischemia. So non ST elevation, and this is ST elevation. Isoelectric, yep. It has to be either 2 boxes above or 2 boxes below, and that's when you'll know if it's either an MI above or an ischemia below. And then you look at T wave, are they rounded and upright? Very important. Basically do the same thing in my own words here. And yeah, something you can look over here as well if you want to. And that's pretty much it. Come on.